I'm Jodeme Goldhar, and I am coming to you from the Change Foundation in Ontario. I have the honor to introduce this session today. My role at the Change Foundation is to join Kathy Fuchs, our CEO, and the rest of our team to build on the work we've done in the past and think about our future around how we serve as a conduit to inform and help catalyze health system improvement and hear from the system in Ontario about what's important to you and what we could do to help support meaningful change. And one of the things that we've done is part of our role is also to connect with people all over the world to understand and see how meaningful change is happening and how we stay focused on creating agency and change and mobilizing around what's most important to us to have meaningful impact. And one of the people who leads health system change and is a conduit to change agency and is one of the world-renowned experts on change is Dr. Helen Bevan. And the Change Foundation and Helen have been working together for some time now to talk about what would be meaningful for a conversation in Ontario. And we've been working together this week to have conversations all across Ontario's health system with different parts of the health system around change and what's important to each of us. And today we put together a panel based on what we heard from primary care would be important. Health system change at a time of change and how to connect to meaningful work and how to rally around what's most important for improvement as Ontario thinks about its next iteration of health and healthcare response. Before I turn it over to Helen, I would like to have our panel introduce themselves. We have two to my right and two online virtually. We've been fortunate to beam in one of Helen's close colleagues from the National Health System, and I'd first like to turn to Dr. Robert Varnam to introduce himself to the 100+ folks that are on the line and all across Ontario, and we also have folks from other parts of the world joining us today. So, Robert, may I turn it to you for an introduction and warm welcome.
Thank you very much indeed. Hello, everyone. It's great to be with you this afternoon. My name is Robert Varnam. I am a GP in inner city Manchester in the north of England. I'm a researcher and improvement leader by background, but I've spent the last decade and a half helping other people to improve their work and helping the system to unleash more of the potential of primary care in the UK. It's great to be with you.
Robert, we're so fortunate to have you join us today. Thank you. And Dr. Sarah Newbery, would you please introduce yourself?
Yes, thank you. My name is Sarah Newbery. I'm a rural generalist family physician, and I'm joining you today from the small community of Marathon on the North Shore of Lake Superior. Thank you for the invitation to be here with you today.
It's wonderful to have you. And to my right, Dr. Jennifer Young.
I'm Dr. Jennifer Young. I'm a community family physician in Collingwood. I am no longer the chief of family practice at the Collingwood General and Marine, but I am now the president of the Ontario College of Family Physicians, and hence my pin. And I'm really happy to be here to share experiences with the UK and to be part of this discussion around transformation and going forward.
Thank you. And to Dr. Rob Ennis, to introduce yourself, please.
Hello, I'm Dr. Rob Ennis, a family physician in Listowel, Ontario, a small town about 2 hours by train from Toronto. It's really great to be here. I've, in my various roles, have seen change opportunities not happen, and so it's a real issue in our province. So to learn from the UK is awesome. I've done work with the Association of Family Health Teams of Ontario and presently with the Ontario Telemedicine Network and the Ontario Medical Association. So I look forward to the discussion. Thank you.
That's wonderful. And a welcome to the Ontario College of Family Physicians and the Association of Family Health Teams of Ontario, who helped put this session together and share with folks across Ontario to join in this discussion. And, you know, we only put the call out a week ago, and we already have close to 200 people on the line for a shared discussion. And what's most important for us today is, as we talk with our panelists and as Helen facilitates this conversation, I will play the role of collecting your feedback and your questions and areas you would like these conversations to go, so that I could feed this in, so that this is as interactive as possible and you get what you need out of this conversation. And so as I turn it over to Helen, just a very special thanks and a huge honor to have Dr. Helen Bevan, who is a catalyst for change and a leading change agent all over the world, who helps us think about mobilizing ourselves, working in partnership, working across teams with people and their families around meaningful change. And she will orchestrate and facilitate a discussion and share some of her important lessons to help inform the conversation we want to have today. So Helen, a warm welcome on behalf of all of us.
And thank you, Jodeme. And it's amazing, you know, that there are so many of us connected in this way. And I think that the group that put this session together were really clear that, you know, we want it to be interactive. You know, we want it to be very engaging. We want it to be a discussion. So just before we get going, just some ways that we can make this session even more interactive and even more valuable. So what this session isn't is everybody sitting where they are passively listening to other people. Okay, it's interactive, it's dynamic. The fact we've got, you know, nearly 200 colleagues taking part here. So if what you can see, there is a chat box. Typically, if you click near the bottom of your screen, you'll see a little speech bubble that is a chat. What we'd love you to do, if you haven't done so already, will you say hello in the chat box? So we know who you are, and you put your chat in the very you put what you want to say in the very bottom bit. And in terms of who you send it to, we'd like you to send it to all panelists and attendees. Okay, if you only send it to all panelists, then only a few people see it. And what we'd like to do is, you know, as well as having what we see on and hear on screen, we'd also like to hear what you've got to say in the chat box. And, you know, let's have a parallel discussion there. And Jodeme has got a special job, okay, to synthesize what we see in the chat box. We will also be asking you to take part in some polls, and that's actually the next thing that we're going to do. And it's in terms of you know, opportunity to contribute. It goes beyond the you know, the actual web session that we're having here. We're also operating on Twitter. So if you want to contribute at the Twitter sphere, then we'd like you to use the hashtag primary care leads, all one word. And I think the final thing to say is that there's CME credit for today. Okay, it's a 1 credit per hour group learning program, and it's been certified by the College of Family Physicians of Canada and the Ontario chapter for up to 1 Main Pro Plus credit. Okay, not that I know what they are because we don't have them in England, but I can read the screen. Okay, so I think what we're going to do now is we are going to have a poll. So if we can have poll number 1, okay. What we want you to do is to click the link. So what we're saying is we need to go back one. Is it going to do that? That's great. So I think it's true to say that physicians in Ontario have been experiencing uncertainty over the past few years. To what extent do you feel optimistic about the future of primary care as the foundation of our health system? Okay. And you can only pick one between very optimistic and completely discouraged. So let's see where we are. Okay. At the moment, cautiously optimistic is having a bit of a battle with somewhat pessimistic. I think we'll just keep going for about another 10 seconds. Okay. So we'll count down 10, 9, 8, 7, 6, 5, 4, 3, 2-1. Okay, so looking at that, I think cautiously optimistic has it with 43%, followed by somewhat pessimistic. So, I mean, only 17% of us are sitting on the fence as neutral. So, you know, if we look at very optimistic and cautiously optimistic, the people that are optimistic, okay, are just squeezed into the majority there. Okay, what we're going to do now is we're going to have another poll. Okay, here is our second question. Okay, to what extent do you see the current state of the healthcare system as an opportunity for successful transformation to a better system of all, including family doctors? Okay, and you can go from this is the best opportunity we've ever had to are you kidding me? Okay, we'll just wait for a little while. Okay, best opportunity we've had before and limited opportunity. Oh no, limited opportunity is a head by a neck. Again, we'll count down from 5 this time. 5, 4, 3, 2, 1. Okay, we'll stop there. Okay, and again, just over half of us say this is a limited opportunity, and 17% of us say this is the best opportunity that we've had. So actually, if we look at the people who are saying it's an opportunity, you know, it's a clear majority. It's 68%. And in terms of the people who, don't think that the future is an opportunity, it's only 10%. Okay, and a few more people sitting on the fence at 21%. Okay, so that's really great. So that's an interesting context, I think, as we start our session. Now, how this is going to work now is we're going to ask our 3 colleagues from Ontario to give an overview of the Ontario context. So we're going to start off with Dr. Rob Annis. So Rob, I think, is going to tell us about some strengths within the system.
Yes, thank you very much. The way we organized this, we thought we would have myself talk about some of the positive aspects of primary care in Ontario, then have Jennifer talk about some of the challenges, and then Sarah talk about the rural context in particular. So just for very briefly and for a minute, and I have to say, as somebody who has seen Helen's talk 2 years ago at Health Quality Ontario, I really want to go completely outside the box here and talk more about the Bodie McBodie issue. Bodie McFace.
Yeah,
Bodie
McBoatface. Yeah.
But hopefully we get around to that. A very good story about how public engagement went severely badly. So the 5 best things about primary care in Ontario from someone who's been in the system a little bit. Number 1, primary care is the point of first contact in our system. And this has been true in my 25 years of practice. It's part of the culture here. It's different maybe than the US and Germany, for example. So I think that is a great piece that's been that persists throughout the years. Number 2, we have great primary care leadership in Ontario. And I'm amazed at this again and again and again. And I don't just mean provincially, but regionally, as well as at the practice level. And I've had the opportunity to see practice improvement in some of the governance work I've done traveling around the province. We have really great primary care leaders that are doing great things. Number 3, we have developed in Ontario a culture of measurement. And this is seen in many contexts. In particular, the Family Health Team Data to Decisions, which is a ground-up measurement initiative, is really taken hold. We have a number of provincial reports that are aiming to improve care that are used, and we have many physicians with an active EMR sector that are encouraging physicians to and primary care practices to pull out data from their EMRs. So this is something that's really taken off in the last few years. Number 4, we have lots of great improvement work, and I'll describe those as pilots with an exclamation mark in that they don't tend to spread, but I know there are many great things happening at the practice levels. And just quick examples, Thames Valley social workers were able to reduce their wait times from 45 to 4 days using a different booking model. The East Wellington Family Health Team has astronomically high cancer screening rates in all 3 of the screening cancers. They've been able to make differences. We have Mira Bacco-Shannon's leadership in the Mississauga Halton Inn looking at improving the medical home neighborhood model in an area where there's not a lot of resources or connection between the primary care practices. So we have really great stuff happening as one-offs all over the province. And the last one is that we have some medical home model uptake in the province. Family health teams have been described as medical homes. We have a number of non-family health team models that are trying to implement the medical home model. I think there is traction there, and I think that bodes well for the future. Okay, I'm going to pass it over to Jennifer to talk about some of the challenges.
Yeah, Rob, just before we stop there, I think that was very compelling to me. I mean, that felt there were some great strengths, and I think it would be really good if other people taking part in the chat box. What do you think are the strengths of the Ontario system? Building on what Rob has just said. So, should we just kind of give it a minute and just see what do you think? Okay, are the strengths of the Ontario system? Okay, beyond what Rob was saying, we'd love to see some comments in the chat box. What are you proud of? Of the system. What's working well? Okay, these are good. Yeah, go on, Jodeme. You can as our chat monitor. What are you seeing?
We have skilled family physicians. We have strong training programs spread across the province. Good oversight and nimble in adjusting to population health needs. Growing recognition of the value. Some of them are moving very quickly for primary community-based care. It's amazing.
Yeah.
Great value of family health teams. Strong interprofessional teams with great working relationships. Great work happening in nurse practitioner-led clinics. Good work happening at the sub-region level where with data to understand the distribution of services. Huge commitment and passion of family doctors and primary care providers to keep improving care for patients despite the systemic challenges that we're all facing. Specialists at understanding local needs, specifically in rural areas. We have a Northeastern Ontario ED network of 27 family health teams that meets regularly to set up 20 standard patient care indicators. There's collaboration between agencies and use of Ontario telemedicine, increasing recognition of specialists and how we can work together to make life easier. Strengths in partnership and community capacity building.
Yeah, so just keep them coming. But in a sense, it's really wonderful, to see so many strengths in the system. So see what you started there, Rob. It's fabulous. So what we're going to do is we're going to see the flip side of the coin now from Jennifer, and Jennifer is going to share 5 challenges, and again after that, we'll get you to put your challenges. And somebody's put there, Helen, after hearing this, you may want to move here. Okay, and just to remind you again, send your comments to all panelists and all attendees. So let's see if you can get a similar spurt of energy and activity going here, Jennifer, by telling us about the 5 challenges.
Yeah, so I get to be Debbie Downer in the group. So I'll start with 5. I think our wage negotiations are protracted and recently quite discouraging in its message towards the value of family medicine and family physicians in the system. Mental health supports, mental health needs are increasing at this time, and we do not have equitable access to primary care, counseling, social workers, system navigators, counselors within in an evenly spread way. Only 25% of our physicians have access to family health teams, and we need to spread that to the rest of our 75% of our family physicians across Ontario. Home care supports are not adequate for the increasing complexity of our patients who are aging and who we are trying to keep in their homes as long as possible. We have EMRs that do not talk to each other between sectors and even at the level of primary care. And I've seen examples of fantastic integration, but it is a long way from being spread across the province. And it's a strength that there are many pilot projects that have been great, but that spread and scale of really good projects has been a challenge. We're all individual, sometimes independent family physicians or family physician groups, and spreading change from that degree of decentralization is difficult. So those would be my 5 challenges.
Very good.
5 of them. But
5 of them, yeah, 5 of them.
hopefully there's not as many as many responses from the group as positive things.
It's really hard when you're a really positive person to have to focus on challenges, don't you think? So let's hear from everybody else as well. Just remember, if you're going to put, what do you think are the big challenges for the system? And again, if you can send your remark to all panelists and attendees. And Jodeme, you have to go quickly this time, okay?
Okay, I'm hearing from Darren Larson that, remember, 75% of primary care is not happening in family health teams, and what is our opportunity? Dr. Tia Pham, waitlists to specialists and advanced imaging are getting worse again. Patient access to their own information, we need that opportunity. Their leadership's training is not available for a lot of family physicians, and what is our opportunity? EMR and EHRs are still very siloed, and there's unpredictability of sustainable funding, lack of system communications, cardiac and pulmonary rehab in local communities is not where it needs to be, and there's a threatened loss or diminishment of capitation funds, funded models. Communication, too many systems not working together the way they need to.
So what I think is great about that, and unless we keep getting them and it ruins my theory, we got a lot more positives, actually strengths, than we got challenges there. But do keep them coming, because what we'll do as well is after this session we will collate all those ideas. And finally, we're going to hear from Sarah, who is beamed in to share the strengths and challenges, specifically within a rural context. So Sarah, over to you. And again, if you're in a rural context while you're listening to Sarah and she sparks you, please put your own comments in the chat box around the strengths and challenges within a rural context. So Sarah.
Great. I'll just check that you can hear me okay.
Loud and clear. Yeah.
Great. So I thought for Doctors Bevan and Varnam, I would just give you a little bit of context to start and let you know that the UK is 250,000 square kilometers with about 66 million people by my last Wikipedia look. And in the northeast and northwest corners of our province alone, it's actually 850,000 square kilometers with about 750,000 people. So we could fit 3 of the UK in the northeast and northwest corners of the province with only less than 1 person per square kilometer. So we're talking not just about corners of or areas of the province that are rural, but also remote. And I would say that when we have adequate human resources in our small settings, the opportunity to be nimble and to be innovative and to do pretty robust quality improvement work that's actually really focused on the needs of the local population is really high. Where we continue to be challenged is when the human resources in our small communities are limited. It can be very difficult actually to even access education and training. I've seen Alan Grill post about the challenge of accessing leadership opportunities and leadership training for family docs. And that kind of training and quality improvement training is even harder to access when you're living and working remotely. But I do feel excited about the opportunity that technology creates for us. The opportunity, I've seen colleagues from Blind River, Minda Moya, Little Current, Sharon Madden, and Sue Lookout, hello to you. So this kind of opportunity to have a conversation and to think about ways that we can spread information, and to Jennifer's point about the challenges of scaling pilots, I think those things are challenging in urban settings, very challenging to spread innovative work in small and remote communities. So I think that's a challenge, but technology creates an opportunity for us. So I'll stop there and look forward to the comments of my colleagues who have joined us from rural and remote places in Ontario.
Thank you so much, Sarah. And I think, you know, well, that's a pretty compelling statistic, isn't it, compared to our country. Again, if anybody is with us, you know, from in a rural context, you know, we'd love you to add to what Sarah has just said in the chat box, you know, both strengths and challenges. And so what we're going to do now is we are going to hand over to Dr. Robert Varnam. Robert and I have worked together for years, and you know, we have a lot in common because we're both transformation specialists, and we both rock the boat and have a hard time some of the time, but we're very kind of determined. And you know, when I knew I was going to be here in Ontario, I just said to colleagues at the Change Foundation, we've got to get Robert on this you know, on this session, and here he is. So Robert, over to you.
Thank you very much indeed, Helen. And can I check, are we going to be all right bringing the slides up? I thought I'd share a couple of things for the visual thinkers among us. Is that going to work? Oh, fantastic, it's starting, brilliant. So folks, I wanted, here we are. Brilliant, thank you. So I need to begin with a conflict of interest declaration for our CME accreditation, just to let you know that I don't have any conflicts of interest. I'm employed by the government, the NHS in England, and by my own GP practice, but in no other way. Could we go to the next slide, please? Brilliant, thank you. And the next one, fab, thank you. So what I'm going to do is briefly let you know about where we're at, tell you a story of the last 5 years, and then we can see what people would like to pick up on. I'm going to do that quite quickly and quite high level. We will circulate these slides if there are other bits you'd like to see in more detail. So Helen and I work in the National Health Service in England, which is part of the UK. That's a lovely little map in case you weren't quite sure where we are. And as a country and a system, we are wrestling with some of, in fact, many of the same issues that every developed nation around the country is, sorry, around the world is. Can we have the next slide, please? We, about 4 years ago now, created something, a policy document in the National Health Service called the 5-Year Forward View. And it was intended to address 3 significant challenges or gaps. And we're going to just list them there. If we could advance through those, that'd be brilliant, thank you. There's a gap in health and well-being. We spend a lot of our time, effort and money on treating disease, and much less effort and time and in creativity on helping people to stay well in the first place. There are some massive disjoints in the way we provide care, and some enormous opportunities to improve care, particularly through changing the model, being more joined up, being more focused around the person, the patient themselves. And we've got some huge funding challenges. Interesting seeing how many people were talking about some of the funding challenges. And so for about 4 years now, we've had a new set of policy focuses in England, which have actually, for the first time in about 20 years, placed primary care front and centre again. Sometimes people tend to think that primary care in the UK, I heard someone describe just yesterday, said, oh, well, you've got a primary care-led system already, haven't you? So it must be easy for you working as a family care provider or being a policymaker in primary care. Actually, I don't think we have. Here's 2 slides giving a little bit of the flavour of primary care at the moment. So in England, the largest part of the UK, 55 million people. Healthcare is publicly funded from general taxation, and we have a long tradition of primary care being a big part of the system. Nearly everyone who lives in England is registered with a primary care practice. Primary care provides about 90% of all patient contacts with the healthcare on a daily basis, but primary care is independent. It's sort of separate from many other parts of the NHS, which are very closely aligned with one another. We are independent contractors. Every one of the practices is an independent practice, has an independent contract. Most of the income, I know a lot of people were asking questions about this ahead, so here's a bit of info about the structure and some funding things. Most of the income for primary care practice comes through a national contract, which is locally administrated. It's largely capitated budget for the number of registered patients you have, but 8 to 10% of it is based on our pay per performance framework, the quality and outcomes framework. Other services from hospitals, home-based nursing, therapy, pharmacy in the community, dentistry, optometry care, those are all separate in the way they're planned, in the way they're funded, and in the way they're delivered. Next slide, last bit of context setting. Currently, we have just under 7,500 practices in England. If you're interested, ask me later why that's falling all the time. And they are members together of 195 clinical commissioning groups. So local planning, local funding of care is organised by these 195 groups, of which primary care has been members over the last 6 or 7 years. A typical practice, the mean is to have 7,900 registered patients, about 1,400 per whole-time equivalent GP. About 370 million consultations a day were held last year, which was about a 20% increase for most practices on 5 years ago. And about half of consultations are with a GP and half are not with a doctor at all. I'm going to tell you the story of what's been happening. I think it's summarised by this next slide, really, which is over the last 5 years or so, everybody everywhere in primary care in the UK has been talking about change. It's not just been the innovators, it's not just been the kind of the excitable, mad, starry-eyed people who've always got something new happening. It's not just been the academics or anything like that. It's virtually everyone is talking about some very, very wide-ranging changes being necessary in primary care provision. And I think it's important to just share a story of why. I think it's a story of what could be two halves, but two halves which increasingly we've been able to bring together. Have the next slide, please. For me, we're seeing a story of response to pressure. There is nothing like a good crisis to prompt people to change. People say that necessity is the mother of invention. We're seeing that writ large in primary care at the moment. Really interesting seeing other people asking about whether physician burnout is a challenge in Britain at the moment. Heck yes, is the answer. I don't think we've been able to experience such pain, angst and low morale in general practice over the last 10 years. It outstrips anything we've ever seen in any other part of healthcare in the history of the health service in the UK, I personally believe. However, also at the same time, we're seeing some of the biggest, most exciting opportunities for improving care for patients and improving working life for physicians and nurses in particular that we've ever seen. So it's really interesting. Everyone's talking about change. Some people are coming at it from a perspective of pressure, some from a perspective of opportunity. And the really exciting thing for me is the extent to which we've been able to bring a lot of it together. Let's just have a quick look and list for you what our biggest pressures are. If we could just advance a slide. So the biggest pressures on us in general practice at the moment are the population's growing, so everyone's getting busier, but consultations in primary care are going up faster. So our population growth is only about a third of the consultation growth. Thirdly, the complexity of what we're doing clinically has been going up possibly exponentially. Next, the costs of work, just paying for the practice, paying for staff, have been going up. But on the other side of the equation, things have been looking bad as well. So the inputs in terms of funding and workforce have not been going up anything like fast enough to keep pace with the pressures. And in the last 3 or 4 years, that's been very significant. So in particular, looking at the workforce, we've seen rates of entry into general practice plummeting. We've seen rates of people moving from full-time to part-time and retiring early skyrocketing. So the pressures have been massive. And it's not just to do with decades, possibly 20 years, of poor national policy in terms of the investment, which we're only now turning around. It's also been because of the demographic change. So if we just look at the next slide, this is an indication we know this to be true. If you click on and click on again, here we go. This is data which you will know as well. It just reminds us that the patients we serve with multiple chronic diseases, who for us are already about 50% of a typical day's work in a typical practice, these are people who don't have a single problem. They don't have a curable problem. It's not just a medical issue, treating it well. And this is the part of the population which is growing and growing. And it's prompted people both to say this is a huge pressure on us, but also to say this is an opportunity for us to reinvent some of the ways that we work, because fully medical care with primary care working in isolation, it's not good enough. We need to work in new ways. If we could just click on 2 more, that'd be great. Thank you. Oh, sorry. Animation problems. Don't you love them? Again, thank you. And again, and just 1 more. Thank you very much. So let's look at, I'm not going to go into detail now, any more detail about those pressures and opportunities, but we've been talking a lot as a nation about new ways of working in primary care in parallel with the need to rescue many of our practices. And so 3 years ago, we drafted something called the General Practice Forward View. If we click on, we just move on 1 slide. Thanks ever so much. The General Practice Forward View, link at the bottom if you'd like to read more about it, is a big new policy with big new investment, about £500 million of transformation funding, and then an annual increase of day-to-day running costs of an additional £2.4 billion a year, invested in both propping up and transforming primary care with new investment, growth in the workforce and diversification of the workforce, measures to help with workload, measures to help with infrastructure, and all of it focused around redesigning care. So a lot of what we've done historically in the UK is, if there's a problem, our only solution is more and more. Actually, what we've done over the last 3 years so far in our policy in primary care is more, but not just more of the same, helping people to work differently. And a key piece of data, I'm glad people have talked about data, let's click on to the next slide, that's informed us, has been a piece of research we did seeking to measure the workload within a typical day in primary care, and to ask GPs themselves the question of whether they thought the work was entirely appropriate. So here's a bit of audit. Again, the links will be available afterwards if you'd like to learn more about this. Asking about consultations in a typical day, GPs have rated 74% of them is entirely unavoidable, but 26%, a quarter of a typical day's work, was rated by the doctor as being potentially avoidable. And 18% in total were potentially avoidable only by action within the practice team. Not a matter of policy, not a matter of funding, but simply working differently. And that has been an amazing opportunity for us at a national level to tap into a lot of the grassroots pilots and innovations in care that we've been able to unearth using a very rapid process about 3 years ago to identify what people are doing to meet the pressures and to work in better ways for their patients. And if we click on to the next slide, we'll see that we have grouped these together into what we call the 10 high impact actions to release time for care. And these 10, I'll read them out very briefly. We can talk about them more if you'd like to know them. Active signposting at the front door, so people don't just always go just to a doctor, they signpost it to the most appropriate person. New consultation types like e-consulting, phone consulting, video consulting, group consultations, reducing non-attendance, massively developing the team and diversifying the workforce, bringing therapists and others into the team, working more productively in core processes, improving personal productivity, a huge focus on partnership working. And for us, this is partly about the medical home collaborative model, and it's partly about partnering differently with hospitals and with community nursing teams and others. A big focus on what we call social prescribing, which is asset-based community development at a personal level, supporting self-care and developing QI expertise. And if you click on one more, I'll show you a link to a website that has loads of information about these. But what's been amazing about this is that this simple collection of 10 ideas of how other people around the country, how existing primary care teams have been helping to work better for their patients and simultaneously release capacity within the practice, has really taken off. And what's been fantastic for me as a GP and as an improver is to see that for the first time possibly in my career, there's been a top-down NHS policy which has helped to spread bottom-up innovation that makes sense to people. It's in one sense just improvement science packaged in a kind of a set of case studies in interesting new ways. And what we've done is we've backed up that spread of innovation with a big new program of practice development. If you click on, I'll tell you briefly about some of the things that we've done in the general practice development program. We've actively spread, we've had a huge program through multiple channels, including peer leadership of spread. We've spread these innovations. Secondly, we've put a lot of work into the how, the improvement implementation. So we've been running breakthrough collaboratives around the country. We've currently got about 50% of primary care practices in England who are part of a breakthrough collaborative to implement one or more of the high impact actions collaboratively to build their primary care network or home. We've put a lot of funding, so my team have been overseeing a number of different pots totaling £193 million a year of extra funding, and we've been crucially building capabilities. We've been training, coaching, supporting and catalysing change leaders all over the country. I'm going to finish by just quickly gathering a thought and then raising a question you may want to ask later on, which is about how it's going. Someone asked me recently, so what's been the approach? I hear the National Health Service is very top down. And I think this is what I would say about our approach. It's been really blended. It'll be interesting to see how it feels for colleagues in Ontario. There's been some big top down policy shifts in the last 3 years, making primary care a priority, shifting money, starting to reverse the decline in the workforce. And at the same time, we've been as deliberately bottom up as we can be. We've been simultaneously building assets and some of the strengths of primary care and addressing some deficits. We've done innovation spread and policy change and creating movements and building capabilities. Last two things, I think, in terms of the flavour of how it's been, is that we have very strongly tried to make this peer-led. We've tried to give it an identity which uses peer leadership more than policy leadership. And we've very unashamedly used a variety of different narratives for change, which are built on what people call the burning platforms and the burning ambitions. We've decided that we shouldn't let a good crisis go to waste. I think we have begun. We've got to a point where, on a candid note, personally, I am more optimistic about the future of primary care in England than I have been for 20 years. But I think we've got an incredibly long way to go. And that's not just about maintaining what we're already doing. I think we need to continue coming up with new ideas and unleashing new communities to lead that change. It'd be great to see what colleagues have to say in terms of their questions and challenges. But that's my very quick story of what we've been doing in primary care. Change, innovation, improvement and transformation in the NHS.
Robert, thank you so much, and it just makes me realise it really it was a very good idea to get you and to come and be part of that. So hang on there, because I'm just going to talk a little bit now about some of our ideas around large scale change, because like what we're hearing from you, I mean, this is massive. This program, it isn't just we're doing these 10 high impact changes in one part of the country. They're literally sweeping the country in a bottom up way. So what I thought I could potentially do to contribute to this rich conversation is talk about some of the ways that we're going about change and seeking to make change happen across whole systems. And what we're seeing, I think, in the health and care system in England is kind of moving away more and more from small scale pilots that don't necessarily spread, to thinking about different ways of going about change. And I thought I would just talk about some of these. So I'm going to start in the top right hand corner. So when we look at what's happening with our change practice and how we're enabling to change to happen much more quickly, I think we're seeing much more focus on networks and communities and informal power. And I think that the opportunities around virtual connectivity, they really enable us to work in different ways. And if you look in the middle row and you go along 3, it says identifying and working through super connectors. So one of the things in our system that we're doing more and more is we're like understanding the relationship between like formal power and informal power. And we're using approaches like organizational network analysis. And what it's showing us is that in a given organizational system, typically there's about 3% of people who are driving conversations or able to influence about 85% of the other people. So, if we try and do like change top down through the system and cascade it, we need 4 times more people than if actually we identify who our super connectors are, the core influencers, and work through them. So, working both with the formal system and with the informal influencers is really important. What I've done here, I've talked about less and more. And the thing about this, it isn't from to, because I think a lot of the less things are things we still need to do, but we need to balance them with the other things. So, as we're working in such complex change scenarios, so we're going to get a new long-term plan in the NHS in a couple of weeks' time, and the whole of our system is probably, if what's in it is what we think is in it, are going to move to integrated care systems, the entire country. So, and it's going to be the biggest, system of integrated care anywhere in the Western world. And in terms of how we make that happen, the changes, the connections, we're going to be seeing, I think, we're increasingly seeing less kind of formal change management and more choreography. As we're working in complex situations, across systems, we need people that can do the dance, and connect people up and, convene groups of people coming together. At the bottom on the left-hand side there, it says about young leaders being at the heart of change. And the evidence on this is really clear. What it tells us is if we want real breakthrough changes, doing things differently, they rarely come from the existing order. So what we need to do is we need to bring in new ideas from outside, and we need to work with young leaders. So the fact that Robert today is in Maidstone in Kent, working with 160 trainee or not very experienced GPs is absolutely, I think, what we need to be doing, and we need to be doing more of that. We need to be doing more virtual connectivity. The fact that, this was only announced last week, and there's 200 of us taking part in this event today. I think, what an opportunity. We need to be doing less kind of formal change management, telling people what they need to do, and more change platforms where we bring people together. We can have different kinds of conversations. You know, very often we talk about top down and bottom up, and we need that. But, you know, we also need to be thinking inside out, and we need to be thinking who our system is. And, you know, very often when we talk about the health and care system, we mean the formal system, you know, the professionals that work in the system. And the system, you know, provides care to patients and families. Actually, patients and families are the system. And we need to think about it in different ways. And also, you know, we put middle lead there. And again, you know, very often we think that people in the middle of the system, you know, the frontline leaders, the middle managers in the system, we think they're blocks to change. But actually, I think we work with middle managers in effective ways, they are an incredible force for change. And then the last thing we're seeing in our system is moving away from doing big 1 year, 2 year, 3 year change programs. And because you know, things are changing so fast, we can have a 2 year change program and you get to 2 years and it's obsolete. So, you know, this approach where we're moving to like 30, 60, 90-day change cycles, even for big complex changes. Because, you know, again, what evidence tells us is that if we focus on what are we going to do in the next month, what are we going to do in the next 2 months, you know, it's a much stronger focus for making change happen. So we've talked a lot. And what we wanted to do now is we wanted to open things up for some questions. So, Jodeme, you know, you've been monitoring the chat box, and what questions are you seeing, and do you think we should be talking about?
There are some themes that are coming out, and I apologize in advance if I'm not getting to everyone's questions or thoughts, but let me share with you some of the themes that are coming out. The first is, how do we enable patient and family-led change? How do we co-design and understand what is most important to patients and families as a result of mobilizing our opportunity for improvement? And that came about in a number of ways, and that's my summation. The second is around, how are you ensuring access to team-based care? Currently in Ontario, there's unequitable access, and what are the opportunities for improvement? The piece is around, a lot of the challenges are similar in Ontario as they are to the UK, as Robert had mentioned. And what are you doing to support physician burnout and also opportunities for primary care to work on quality improvement, because there are some comments that we don't have the support and the resources despite the will and the want. And the final theme is, how have primary care physicians in the UK and Britain been involved in informing and influencing policy, and has it been respected? And those were some of the key themes that have come up that may I turn to you to address.
Yeah, I think Robert should start.
Wonderful, Robert.
Take your
So I
pick,
think
Robert.
I completely agree. They're fantastic questions and some really great challenges and ideas here. And to address one of them that people often say, like, interested in learning more, the slides include some really useful web links, but also my Twitter handle. And I'm really happy to continue the conversation in any way it's helpful for people. So 3 great questions you just raised there. One, I'm going to go in reverse order if that's all right. One is about how we have helped to influence policy. Partly it has come about through the fact that the pain on primary care has reached critical point in the last 4 years. Practices have been closing. People have been retiring 5, 10, 15 years early, to a point where it became almost non-ignorable. I think the other part of it is just that we've had some people involved in national policy who've championed primary care, and it's partly just been determination on that front. But the second thing is that we've been able to talk about it as being not just a plea for more money. So the difficulty in the policy space is everyone's kind of gets quite protected against the plea for more money. We've been able to talk about the need for more money, but also to say there are so many opportunities to improve just with our existing resources and ideas, and we're not having to reinvent the wheel. We've got things, we just need to spread them, and that's so much less effort, so much cheaper, and that's really, really helped. I think that's also helped with some of the buy-in. Lots of people have asked sort of questions about how we've got people engaged, how we got primary care physicians involved. Partly it's just through desperation, but partly it's because we've got a whole set of very practical ideas and movement growing based around the implementation of quite practical new ways of working that make an immediate sense to an everyday primary care provider and help us to meet some of the big national strategic objectives about improving population health and the sustainability of care. And then the last thought, the question about physician burnout. What have we done about physician burnout? Is this an issue? It is a huge issue. I think we've done three things. At a national level, we've shown that the system's heard, that we care. We've got, national leaders putting large amounts of focus on it to show people care. That helps morale. Secondly, perhaps way more importantly, we're improving the job. We're helping people to work in more sustainable ways. The 10 high impact actions are a big part of that. And then the third one is actually we put some funding into targeted mental health support for physicians experiencing burnout in primary care.
Yeah. Thanks, Robert. And maybe one thing I would add is about system relationships are changing. I mean, we used to have a system where the different sectors were so siloed. And I think that the shift towards clinical commissioning groups and family physicians and primary care coming much more into the ascendancy. Do you know that we used to have in the NHS a leadership council for leadership improvement, and there wasn't a single person from primary care that was part of that. And I think that over the past period, as a system, just the effort and energy that has gone into building leadership in primary care, I think is making such a big difference. And the leaders are there. The leaders were there, but in a sense, we didn't develop leaders. And I think there's a whole new amazing generation of primary care leaders that are emerging, and they're system leaders. In terms of the big population, we are just about running out of time. So I hope that what we take from this is that there are massive opportunities. Even when there are many challenges, and the fact there's so much energy here. Let's take this in terms of thinking, where do we go from here? How do we continue to build this movement, building on all the great work that is happening already. So we've hardly got any time left. We're going to ask Jennifer to give us some closing remarks, and then we're going to, and please stay with us because we're going to run over time, really bad sharing, but we're going to have 2 closing polls. So Jennifer.
So thanks to the Change Foundation, to Drs. Bevan and Varnam so much for your contributions. And thank you all for joining. I'm so impressed at the number who are here. This discussion reminds me of the movie Finding Nemo. There's a little fish in a big net, and his dad says, we got to get Nemo out, and you've all got to start swimming as hard as you can. And everybody does that and swims as hard as they can, but it isn't going anywhere until he says, swim in the same direction. And through swimming in the same direction, good old Nemo is saved. So, thank you for helping us to look at swimming in the same direction.
Yeah, fantastic. And thank you so much, Jennifer. And then finally, we have our last 2 polls. Okay. So this one is, it's a very profound one. Okay. Was it useful? Yes or no? Okay. Some of you said they couldn't do the polls, so I'll do a verbal, annotation. Okay, so at the moment we're saying 90% are saying yes, it was useful, and 10%, 11% said it wasn't useful. Okay, so if you can't see the poll, it's about 90 and 10. And again, it would be great to get your comments in terms of what you thought of it and what issues and where this conversation needs to go next. If you can put that in the chat box. Okay, and did you perceive any degree of bias in any part of the program? Okay, and we're at 100% no. That's a relief. Okay, one person. Okay, one person has said yes, but everybody else is, so it's 98% no. So, and I just find I would like to congratulate the Change Foundation, because, you know, we've never done and you've never done a session like this before. And I think, you know, for your first ever Zoom with the primary care community, I think it's been a triumph. So, you know, let's hope this is the first of many. So, so thanks everybody. Thanks to all our speakers, and let's all be Nemo.
Yeah. Bye everyone.